a child psychiatrist, chairman of the Medical Board of Singapore's Institute of Mental Health and adjunct associate professor at the Yong Medical School, Duke in US Medical School, National University of Singapore, and Lee Kong Chian School of Medicine, Nanyang Technological University. Recipient of the Singapore Psychiatric Association Book Prize, the Vice President of the International Association for Child and Adolescent Psychiatry and Allied Professions, recipient of the Platinum Service Award in 2017 for his work with children who have been abused, President of the Singapore Association for Mental Health from 2009 to 2016, an NGO that supports mentally ill persons and their families. His research on anxiety disorders and disruptive behaviours in children is supported by the National Medical Research Council and other funding agencies. He would have been here with us day before yesterday, but it was a very important event that kept him away. He and his team were awarded the National Medical Excellence Award for enhancing mental health services for children. Let us all congratulate him and welcome Daniel Fung to talk on developing services for autism from hospital to home.
Thank you. Can I have the first slide? Someone has to click it, I think. Sorry. Can you all hear me? Well, it's a hard act to follow, you know, after what was shared, but I'm coming really from a professional side of things. What I will share is my own personal journey of understanding autism as a disorder, but also how we've developed our services in Singapore to better meet the needs. And I chose this title, From Hospital to Home, because that's where healthcare is going today. Healthcare isn't about hospitals and clinics. It used to be, but healthcare is about each one of us, about how we take care of ourselves. The definition of health, if you understand it, is very holistic. It does not restrict itself to just medical services. So one must go away from that thought that healthcare is about hospitals and clinics and specialists. The real experts in healthcare are each one of us here today. And I think that's an important thing to think about. Some disclosures here. Thanks to CADRRE, I could come here and this wonderful place. I understand this is an oasis in a very difficult time that around Kerala, and I think we feel for the people who are suffering. I just heard this morning that many people have passed on as a result of the floods and the rain. But I'm here, thankfully, safely. I flew in last night, so pardon me if I feel a little disoriented and sleepy. I'm going to do four things really. A short introduction of the concept of ASD from a medical perspective. Tell you about the medical model, which is what we traditionally understand a disorder. And then talk a little bit about what it means to the social and educational realms. And then we'll share about the Singapore experience. And I start with life, right? We all live. We think of life as the birth and the death. Before that, perhaps fetus. Is that life? Well, there's arguments about that, you know. And then, is there an afterlife? Now, I'm a doctor, so people always ask me, when you talk about afterlife, I think that spiritual dimension is important for all of us to think about. Okay. Now, at birth, we look with hope and optimism. It is about growth. And as we age, we start thinking of death. Now, I'm a little younger, perhaps. I don't know whether I'm young, but I think I've done 2/3 of my life. My final third is now part of that journey. And I am also thinking about aging. Like Singapore, we are a rapidly aging society, perhaps one of the fastest in the world. When we're young, we talk of resilience and strength. As we grow older, we worry about our problems. But really, this is a spectrum of life. It's a journey that we all take. Now, this is where the differences lie in a lot of our knowledge. The East versus the West. Collectivism as a society versus individualism, and what we each individual stand for. medical development and healthcare development has been focused a lot on treatments and identifying illnesses. But if you look at the East, and honestly, I don't know much about India in detail, but what I do know, and most of Asia, is that we really lack a lot of medical services. If you go to the West, you go to Europe and you go to America, Australia, there are a lot of services, maybe 1/4 of the people are involved in healthcare. But yet we are able to manage our populations. How does that work? Because there is socialization, there's integration already within our societies. So autism spectrum disorder, what is it? Well, you could call it fake news, you could call it anti-psychiatry movements. Every time I give a talk as a psychiatrist, I go to a big meeting, there'll be people standing outside, complaining about us medicating people, Maybe. Then you look at the two ends, right? Socialization, families, parenting, abuse, trauma, learning, bad behavior, sociopathy, as the social aspects of how we look at problems, versus medicalization. Actually, the concept of medicalization is relatively new. Only in the 1970s, a French philosopher once spoke of this, how we've used clinics to create a clinical gaze to look at people. Oh, you've got a disorder, you're ill. Some disorders are so common that they occur in 70% of the population, in which case I think they're probably normal, right? So when you take a medical model and you do clinical gaze, you start to see problems. If you do a scan of a brain, which brain is the same? Why is it that we do not understand, now that we have mapped out the genes of our human body, some of the differences that we have? Because it is in our humanity that we are different. That if we put everyone stacked against each other, we're different. Everyone is unique. There is no identical person. And so if you take a very medical model and you try to identify problems, this is the issue. Of course, people are studying this. Genetics, cognitive functioning, that's the other side of the spectrum. So I want you to take that context, that there is no real answer, but a broad understanding of things. And that's life. What about mental illness? It's a long history. It's very stigmatizing. People don't like to be called someone with an illness, for one. And they're very broad. So a lot of people assume mental illness as being one disorder. Oh, you've got a mental illness. Okay, please stay away from me. We've got these places, good places for you to stay. They're called asylums, institutions, hospitals. I'm the chief psychiatrist of a hospital of 2,000 beds. In Singapore, it's the largest institution. Where was it built? It was built in the northernmost part of Singapore. It's far, far away. Today, it's in the most populous part of Singapore, but, and people start to complain, oh, I'm living next to the mental institution. But we say, oh, we're here first. If you don't like it, you can always go somewhere else. But we've been there since time immemorial. Singapore used to be just the central part of Singapore, right near the port. And actually, our hospital used to be in the jungles. They think it's in Malaysia, because it's very far away. But we put mental illness as as kind of a problem, a stigma, put aside, but actually it's very broad. It actually encompasses a lot of problems, whether it's in thinking, in feelings, in behaviors. So it is a very broad concept. Sorry. But the problem with our systems today is that we've divorced mental illness from physical illness. The head is separated, the mind is separated from the body. And that actually creates a lot of problems, because health actually is holistic. Now, these are, burden disease studies are done by WHO to try and understand the impact of an illness on society, whether you lose your life to disability or you lose your life completely. So cancer, your burden is high in terms of lives lost because you die. In chronic illnesses like diabetes or mental illness, many mental illnesses are fairly chronic, lifelong. You lose life to disability, so you don't have a complete, so they do a calculation, and burden of disease. So mental illnesses are relatively common burdens particularly at a young age. And autism, of course, is within that rubric. All right, you can see it there. This is Singapore's data. So we're quite aware that it has significant burden. Oh, I thought someone was taking away these slides. So what is autism? Those slides are actually from 2 storybooks. Okay, I know there's some sensitivity about animals, so I was told we'll take them away, but it's still there. What I will say to this is that it's an interesting concept because people look at behaviours and then they kind of correlate it with certain behaviours that they notice, right? So those 2 storybooks are quite interesting because in Singapore, pets are quite common, and they compare kids with hyperactivity and ADHD, more like dogs. Kids who are a little bit more sensitive, they're like cats. I actually have 3 cats at home. One of them ran away, so she's left our home. The other one hides, never comes out, very shy. And the third one is the boy cat, so he's a bit different. Now, I say this, I don't mean to demean any of you. Comparison with animals, it's just a caricature, all right? We all do this, at least in Singapore. What I will share with you is this concept of autism awareness. This is an interesting study. It's done in Nepal, all right? And they asked several questions. So the first person that they described, and then they asked professionals and parents, what did they think of this boy with autism? This was their description, you know. Autism was one of the characteristics they described, but they described, most people thought this was a stubborn child. The second one is a boy with ADHD, attention deficit hyperactivity disorder, very hyperactive child, okay? ADHD, in fact, was seen as very, very low, you know. In fact, it was like naughty, pampered, insisting child. The third one was a child with intellectual disability, global developmental delays. What did they say? Slow-minded, dumb, all right? So understanding is a little better, perhaps. And then the last group is a girl with possible autism, shy. Notice the differences, how people view autism, right? Depends on where you come from. You know, what's your perspective? So it's interesting to look at this. The next thing is, do we know about what's the prevalence of autism? This is a very recent study. What we know, most of the data that we have in terms of prevalence studies are really from the West, from developed countries. Asia, and you can see there, South Asia is, I don't know whether you can see, it's South Asia over here. Is that pointer working? Pointer doesn't work. Never mind. South Asia, you can see right in the middle there, there's no data. There's Southwest Asia and Southeast Asia, small numbers, but very little data that we have on prevalence, all right? Oh, I see, I've got that slide. So how common really is autism in this part of the world? Today we are saying that it's more and more common. In fact, we're not sure. Is it because of the changes in diagnostic criteria that doctors are used to? Increased public awareness. I mean, 10 years ago, we wouldn't have this conference. People would not be talking about this. In fact, in Asia, it's a thing of shame. It's embarrassing. I know that I come from a Chinese society. My brother is intellectually disabled, or somewhat intellectually disabled. I think today I could probably refine it a little better with a nicer term. And my parents would not talk about his problem. They'd go for help, but they would not talk about it. So today we are willing to talk. We can share a lot. So more is out there. There's greater education. There's a lot more training. Global prevalence per 10,000 has been increasing dramatically in some parts of the world. In fact, in Korea, the figure is so high, it's like something like more than 2.6% of the population. That's a lot of people. And one wonders if this is indeed true, or is it that we are being able to get people to come forward more. Sometimes it's also the way we've classified certain groups. So in the past, we used to identify people with global developmental delay and intellectual disability. Now we are moving them onto this autism spectrum because people are more aware. So this is some of the figures. I won't talk very much about this, but there is a rising prevalence. Now that could be a real increase due to environmental changes, the world that we live in. Remember, our brains, as we grow up, are now inundated with information. How does that change you? How does that make a child behave? We're not quite sure because we have no real idea at this point. Now, let's move away from the concept of disorder and illness to the concept of well-being. Health, as defined by the World Health Organization. This is the preamble to their original constitution back in 1948. Health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. So that's health. That's very global, Actually, if you look at that definition, I wonder which one of us here can say they're truly healthy, right? So healthy means no mental illness. Mental illness means not healthy. Is that true? Not necessarily, because well-being is on another dimension. You can be, and I suppose the easy layperson term for well-being is happiness. You can be a happy person. You can be ill, but still be happy. Or you can be ill and very sad. They are actually statistically independent concepts. So you can flourish with illness, and I'm sure you've met people who are very happy with an illness, with a disorder. You can flourish, obviously, without any illness, and we'd all like to be in that blue corner. But we can also languish with illness, be very unhappy, say that life's been unfair to us. Why do I have this illness? And when I work with kids, that's one of those things that I have to deal with. I can treat the illness. I'm not sure I can treat your well-being, because that is a broader concept. And that's important to think of. Now, let's look at medical diagnosis of illness. This is historical, from as ancient Egypt, there's the concept of what is a disease and how do you explain it based on how they present, symptoms and signs. In ancient China, the first emperor, the Yellow Emperor, had 4 diagnostic methods. Not very different from what we use today as doctors, all right? Inspection, auscultation, interrogation, which is history-taking, palpation. I think they miss out the percussion piece, but that's okay, It's pretty comprehensive. So the concept of illness has been around for a long, long time. But what about mental illness? This is where I have the biggest problem. I have a problem with our categorical system. We love little, doctors probably are the most autistic, if you think about it in some ways, because we love these categories. Everybody's got to be in a category, And it's a categorical yes or no. We try to then define that symptom or sign related to a syndrome, which then we find a cause. Now, this works perfectly well for infections. If you've got a disease, you've got a bug, a bacteria that causes the disease, we can treat that. We'll find that bug, we'll kill it, or we'll make it very weak so your body will kill it, and then that's how you deal with it. That works for acute illnesses, for causes that are known. But when the cause is unknown, as in many mental illnesses, we rely on these classification systems to give us our arbitrary diagnosis, right? And the ICD-11 actually has been released, all right? And then the DSM-4 and the 5, they've all been classification systems around this. They try to go around, to manage a dimensional approach, but it's very difficult. There are new concepts that the National Institute of Mental Health in the US has tried to use this concept of research domains of looking at the underlying cause of illness. And it's a new way of looking at pathology by identifying what they call endophenotypes. So, for example, if you are not able to read or you're not able to interact with people, what's the cognitive function that's in deficit? And then if you can identify that and break that down, that's one way of looking at illness. But that's still a new concept. The person who initiated Tom Insel is now gone in the commercial company, so I don't know how they're going to push this forward. But it's an interesting new concept, all right? And of course, autism spectrum, we're trying to look at that. I've spent a lot of time talking about the background because it's important to understand this. ICD and DSM, these are 2 classification systems. They're long histories. You can see from 1949, 1951. They're kind of merging. There's some differences. Earlier speaker talks of gender dysphoria, which is a DSM-5. The ICD-11 has come up with a new term, you know, gender incongruency, I think, is the term that's been used. So it's difficult. These classification systems are just naming, a form of naming games. But nonetheless, it does help you to sort of understand the signs and symptoms. So these are some examples. I won't go into this because I didn't, you know, I wasn't sure what kind of an audience I'm talking to. So I'm sure you can look it up. You can Google ICD-10, DSM-4. They're all there. ICD-11 is out, but ICD-11 doesn't have the criteria which ICD-10 has. And I'm just, you know, this is just a quick oops, sorry, went a little bit too fast. In autism, in DSM-5, actually, they brought everything somewhat together and call it a broader term. So in the past, we used to have high-functioning autism, you know, autism due to various problems, and brought it together as an autism spectrum disorder, which is just a reorganization of classification. I thought you should know that. And what about the outcomes? What happens to children with autism? If you follow them up, this is the kind of outcomes that studies are suggesting, okay? Only 20% have good outcomes. 30% have fair, means they struggle, but they can get along. And the other half actually have very poor outcomes, right? Over time. But that is really dependent on what society does for them. The other thing that's common in autism research is the fact that there are many, many conditions associated with it. And so this whole bunch. I think we heard about, you know, the association with gender dysphoria. Perhaps that's one area, but these are the big common comorbidities, or what we call common disorders that are associated with autism. So that's the medical side of the picture. What about the educational and the social side of things? So this is from our Ministry of Education's website. It says, choosing the right school. You know, and in Singapore, autism spectrum disorder is classified as a disability, a learning disability that allows you to have special support in school. You can go to a special school if necessary. So that's the way education is. Can you learn? But if you think about this concept of well-being and education, you'll realize that they're linked. And Singapore is one of those high-stress Asian societies, all right? We don't have very high suicide rates, largely because we have a lot of support systems. I'll share that support system piece with you in a while, but it's still a great impact. Every time I see a youth suicide, all right, we're talking about learning-related issues that drive them towards that act. And the suicide is the tip of the iceberg. Many unhappy people kill themselves eventually, but a lot of them are suffering in silence. All right? So it is important to consider what the school system does for a child's well-being. And if you don't have a good system that supports the child, then the well-being is impacted and you have a very unhappy child, regardless of whether you call it a disorder or not. Now, if you take a medical approach to autism, remember we said you classify, you diagnose it, you identify, then you treat. Before you treat, actually, you must prevent if you can. So in medicine, we always talk about prevention before we talk about treatments. But in autism, because we don't know the cause, it's hard to do primary prevention, which means preventing it at the root cause. But we can possibly do early recognition, and many systems in place today do a lot of that. That could account for the increasing prevalence, right? We're identifying kids early. By the age of 3, you can identify some signs and symptoms. You could get them to help earlier. Then you treat the problems, but the treatment is complicated. What is the treatment? Because in medicine, the treatment is often with medications. Now, I may be a doctor and a psychiatrist, but I don't subscribe to the whole idea, the concept that we're totally biological beings, that all medicines can cure us. You can't give a pill for a divorce. You can't give a pill when your child is not listening to you. Well, maybe you can. You put the child to sleep, I suppose. But it's hard to treat problem behaviors with a single magic pill. And that's the problem. Well, we could treat complications. Some complications are physical complications. In autism spectrum disorder, the association with epilepsy, you have to treat the epilepsy because that would damage the brain otherwise, or even worse outcomes. They could kill the child. But an educational approach looks at how the child is functioning. That's a social approach. It's looking at what skills the child needs that they lack. And we all have skills and we all have weaknesses, right? I know that one of my big weaknesses is actually speaking in public. So I don't appear to be so because I'm old enough to have trained myself to do this. It's not my natural inclination to come forward to a group of people and tell you stories and things, but I train myself. So if you can do that, you can do that with any child, right? You train. And our children learn this. In our societies, we learn this by example, by role models, practice. And so you can learn various life skills that will help a child with autism spectrum disorders to adapt. The world is difficult, yes. You know, we could say, well, let's wait for the world to change, or we will change ourselves a little to cope with it. But we'll still be in our default states to some degree. So these are some of the things that schools do. So, what are the choices we have? We can have educational interventions, which are large, to me, for a child, is school-based. All children should go to school. It's a basic human right to me. And I believe that we should try and make that happen. If you want to sort of work at societal level, the most important thing is schooling. Because it's a social environment, there are lots of powerful motivators, and it creates that a society that can function together. If you start any country, I think the first thing to do is to make sure that there's schools. So educational interventions are very powerful. But when there are problem behaviors, schools reject these students unless you are aware of the problems, unless you start to think about how to help these children. Now, whenever there are problem behaviors, and I have many schools, I worked with all 350 primary, secondary, and junior colleges, including special schools in Singapore. And the award that I was given as part of our team was really working with schools. So in the last 20 years of my life, I've been working with schools. Very often when schools have a problem and the child's not learning, they send to the doctor and says, please help. Do you have a magic pill? He's not paying attention in class. He's very disruptive. He's very odd. He's a loner. Someone's bullying him, and so forth. All these problems. And as a psychiatrist, I used to think, gosh, okay, which pill is it for abuse? Let me think, and it has grown. When I started in psychiatry, we only had maybe 10 medications. Now we have a lot more. We can still give out one pill after another. That's medical interventions. But some of this, for this group, developmental learning related problems, people are starting to look at other, but they're calling them interventions. Now, I've used the word unproven, doesn't mean that they don't work. They're just not proven. That means not scientifically proven. We haven't done randomized controlled trials, but I have another problem with the randomized controlled trial. We can talk about that later in our discussions, but there's a whole bunch of stuff, okay, unproven. The only thing I have to say is medical treatment, if they are well proven, very often governments should pay for them, and they should be affordable to the average person, right? And in Singapore, we made it so. If we've got good evidence, we will pay for the service. It's just that when there's evidence is not good and the price is very high, just beware, okay? There are risks and there are costs, both of which are important. There are no medications actually for autism spectrum, but there are medications used to treat specific behavioral problems. And I put this slide up. You don't have to really know it. A means good evidence with, and D means, some people have talked about using it in guidelines and so forth. And there are various treatments available. But more important is not what choices we have, but how we should organize ourselves to help people with autism spectrum disorders. What are the kind of professionals and skills we need? What are the groups that we need to address, whether it's children, adolescents, or adults? And what kind of community resources can we leverage on? Now, this is Singapore's example. We know that the figure is going up. We don't have formal studies, but we assume that because our schools are having an waiting time, we have special schools for learning disabled as well as autism spectrum disorders, and each one of them have waiting lists. So many of the students are actually waiting. We know that there is a rising prevalence, all right? our most recent enabling master plan for special education actually looks at this, and so there's a need to develop services. So how should we develop services? Remembering what I said about how we should organize ourselves. I give you an example. This is from the UK in London. This chap is Jon Snow, but I don't know whether you all think of Jon Snow as the Jon Snow in Game of Thrones. It's not the same Jon Snow. He's touted to be the father of epidemiology, and it's about public health, right? About how we can look at interventions, both at primary prevention and more importantly, secondary prevention, especially if we don't know the cause. He actually identified in London the cause for cholera by looking at the water systems. Because cholera outbreak was occurring around the water system, he could say, hey, look, it's happening here. So it's stepping back and looking at the big picture. The big picture of autism, what is the issue here? Is it about children running around, odd children taking over the world? Or is it about how to help them manage themselves in our school systems, to give them a better life, that they can integrate better and work with the rest of society to be meaningfully occupied? If it is that, then what must be developed to help these children? That is the key. So the principles of public health are important in this designing of a system that will work. Right? So first step really is getting people to understand autism spectrum. So things like clinical guidelines for doctors as a first step. This particular clinical guideline actually had educationists involved, and this was specifically looking at preschool, which is the first step really. When children go, before they start formal schooling, they go to preschool. And that's where we pick up a lot of the kids with problems and identify them early, coordinate, rather than wait until it's much later. Gee, I got 12 seconds left. Okay, I'm going to talk a little bit about Singapore's healthcare strategy. Our healthcare strategy is really leveraged on three things, all right? From healthcare services to health, which is personal. Move beyond hospitals to the community, to our homes, and to create value rather than just have quality services. In healthcare, we've been, for a long time, been obsessed really with trying to make services very high quality. And then it costs a lot of money. You know, high quality is like buying a Porsche, right? A fast car. It's a beautiful car, but not many of us can afford it. Versus having a good value. I know I used to say Toyota cars are a good value. Now I'm not so sure. So, you know, maybe it's one of the Korean cars or what does India produce? You've got cars of your own. Value is what we're looking for. Right? Value to the individual and to society. Then we have three strategies for resources. Because remember, we don't have a lot of people. Singapore's got a population of 5 million. Not like India, you have lots of people. That is a bane and a boon. But we don't. So we have to try to cross-skill people. So in our health community teams that we've started to put the professionals side by side. Social workers, psychologists, occupational therapists. Guys, you need to work together. I know you have your professional boundaries, but you have to learn to work beyond those boundaries and use technology if you can. I'll share more of this. So this is our strategy. This is how we've developed our services over the last, this is up to 2000, all right? So it's actually 40 years. Whoops. Does it mean that I cannot speak anymore? my screen has disappeared. Okay, so we have tried to combine education with health. The whole concept is really to put the two together so that we can develop services that make sense to our population. And instead of trying to have different services, think about how you can bring the two together. So one of my efforts in my career has been built around trying to bring healthcare into the school system and not have disparate systems. I don't have much time to go into the details, but I'm happy to take questions as how we develop our clinic and how we sort of bring the services from a diagnostic one really into a service provider one in which it's school-based, right? That's disappeared again. Sorry. And then this is the kind of team composition, which is multidisciplinary, but I'd like to say that a lot of the work is interdisciplinary and transdisciplinary, where we work with one another. And that's important. Now, I understand from CADRRE that you guys have got that kind of a system in place. That's a very good start. What you need to do is draw in the health system into this whole picture. This is just to show you our work. It's gone up over the years, and we managed it because we work not in isolation, but really in relation to all the services. If all the teachers in the schools are appraised to health and healthcare and mental health care, then we've got a whole new workforce. The other workforce that I haven't had time to talk about is really what I call the families themselves. They have a lot of power within themselves because they have an individual that has a problem in school. So caregivers, parents, even the children themselves could help one another. And that's part of the human resource that you have to think about in developing services. This I won't talk very much about. It's about the research that we do. It's important to research what you are doing and trying to incorporate, so that there are two things. One is, this is dealing with feelings. It's something that's very easy to get across. So in our institution, one of the things that I like to tell people is that you're saving lives, one feeling at a time, right? So it's a powerful message. The other, of course, is using, this is a bear that's able to interact with a child with autism, and we've done some work on that. Okay, so finally, in conclusion, really, 3 areas, all right? Patient satisfaction, population health, and cost-effective care. Those are the areas. So in order to do all of this, we really have to move away from the illness model alone and consider another model, a more population-based, community-based, well-being model about how we integrate. And then, of course, it may mean that we need to manage all aspects of autism care. We need to be able to involve everyone, which includes self-care and caregivers. And we need to, of course, leverage on technology. And I think today, India is a very technologically advanced society, I think, or at least some parts of your society. The ability to, just by a show of hands, how many of you got a cell phone, mobile? You all have. The cell phone is one of the most powerful devices that we've got. It is a monitoring device, it's wearable, everybody uses it, it tells you stuff, and it captures things from you. So it's a beautiful device that we could use in healthcare. Today we're looking at what we call digital phenotyping. How you use your cell phone can maybe describe an illness or your well-being for that matter. So thank you very much.